My name is Vibha Krishnamurthy, and I am the Medical Director and founder of UMMEED Child Development Center in Mumbai. My colleague John Thattil is our Chief Operating Officer, and he's with us here today also, though I'll be making the pitch. This is the name of our project that we are going to be talking about our project, which is called Scaling Up to Reach More Children with Disabilities. So by background, I am a developmental pediatrician. And mostly when I tell people that I'm a developmental pediatrician, they look a little puzzled. They want to know, did you say developing pediatrician? You look kind of old for that. They're looking that, they're not saying that. And then when I explain that I work with children with disabilities, there is a look of polite interest, and most of them, their eyes kind of glaze over a little bit. Because unless this really affects your life in some ways, 8 out of 10 people think that it doesn't affect their life in some ways or the other. I hope in the next few minutes to be able to convince most of you that all of us need to be passionately involved in this. So here's one statistic to begin with. At least 1 in 10 children has a developmental disability. And when I say developmental disability, I'm talking about anything that causes a delay or difference in a way a child learns to walk, to talk, or to learn. There are 2 ways you can acquire a developmental disability. You could either be born with one. So this little boy is called Tanay. He is my patient. He came to see me when he was 2 days old. His parents brought him as a newborn baby. And they were sad, unusual for parents of a newborn baby, but they knew he had Down syndrome. They knew that he was going to be delayed with respect to his learning, with respect to his walking and talking. His genetics determined his potential. But on the other hand, this is little Prakash. His mother works in the fields in Rajasthan. His 12-year-old sister takes care of him. And the reason Prakash is going to have a delay in how he talks and he's going to have a delay in how he learns is because in all likelihood, we all know the statistics, 1 in 2 children like him are malnourished. That delays your learning. 8 out of 10 children are anemic under the age of 3. That's a statistic we all know. And most importantly, the person who looks after him is his little sister. She doesn't know how to stimulate him the way a parent who really knows how to stimulate him could. What I mean by that is reading to the child, talking with the child, playing with the child, something that most of us who are parents here in this room take so much for granted. The interesting thing is, the solution to both these kinds of disabilities is exactly the same. What you have to do is to identify early when a child is at risk or when a child is going to have a developmental disability, and teach the caregiver, teach the parent how to stimulate the child. Teach the parent how to read to the child, talk to the child, play with the child, sing with the child, exactly like you and I would do for our kids. And that has solid backing in terms of data leading to better outcomes. What do I mean by better outcomes? Literally better school performance. Better job performance, better job opportunities. There's a lot of long-term studies that point to the fact that early intervention has good outcomes. Why am I going on about the early years? So this is a brain scan. It is not very difficult to understand this. The black part is the developed part of the brain. So look at the brain scan at 5 days to 1 year and 1 year to 28 years. Where is the delta more? Where's the difference more, right? Clearly between 5 days and 1 year. It's not so dramatic between 1 year and 28 years. And the reason for this, and look at the study, it's from 1997 that I'm presenting this. We've known this for years, at least a couple of decades we've known, that the brain develops, the human brain develops surprisingly rapidly in the first 3 years. 80% of the brain's growth is done by 2.5 years of age. Right? The next slide I'm going to show you is also a brain scan. Bear with me, I'm a doctor, I like these things. The one thing that I have to tell you is the early stimulation and its importance for brain development. Why is it so important? Such a simple thing. Why is it so important that I talk to the baby or sing to the baby, right? Look at this scan. Now the way to understand this PET scan is red, yellow, and green is good. They're good parts, the brain is active, functioning. Black means there's no activity going on there. The parts that are circled are the parts of the brain involved in language and in social skills. This is a healthy toddler, and what you see is that there is lots of activity going on, red, yellow, and green, lots of it inside the circle. The next slide I'm going to show you is a PET scan of a little toddler in a Romanian orphanage. This study was done by Charlie Nelson from Harvard, And what he did was, it's a famous trial called the Bucharest Intervention Trial. And if you look at the next slide, you will see what happens to a baby who gets good nutrition. This kid got food. He wasn't anemic, he wasn't malnourished. What he did not have was a caring parent. And that's what happened to his brain. So there is some urgency to what we're talking about here. If there are so many children at risk, what are we doing about it? So how big is this problem? Our WHO statistics, as well as a famous Lancet series in 2007, suggests 15%. And that's why I said at least 1 in 10 kids. What does that mean? 52 million children in India. That's the size of, I think, the population of Spain, if I'm not mistaken, something like that. In this comes UMMEED. The word UMMEED means hope. And what we really want to do is to reach out to children with disabilities or at risk and help them reach their maximum potential. Those are the 2 categories of children we work with. How we work with children actually has a 4-pronged approach. But UMMEED does a lot of activities. I want to focus on 2 of them specific to our project today. Oops, I'm sorry. Our Center of Excellence and our plan to build capacity in other organizations to scale up. I'm going to talk more about it. I want to talk more first about our Center of Excellence. This is in Parel in Mumbai, and I invite any of you who are here to come visit. It began as 3 people wanting to provide service delivery under one roof for all families of children with disabilities. Today we have 55 professionals. What is unique about what we do is that the family is our focus. We are not child-centric. This doesn't sound like rocket science. It sounds intuitive. Of course, if you want to work with young children, you have to work with their families, but it's not. Unfortunately, the way practice runs in Bombay today or in all of India today is very, very child-centric. We have about 6,500 visits a year where we provide direct services. But what is most important is when I'm getting to the next part, I'll tell you that what we do here is build best practices for our country and our situation. So there are lots of studies outside that show that early intervention work, that it's really wonderful to have these services available. But are they specific for our context? To give you very simple examples, what about extended family? What role do they play? All our families are large joint families. To give you another example, what about the cost? Neither the healthcare system nor the education system is picking up the costs. So who's going to do it? The buck stops with the parent. So how do you do therapy in groups? How do you work with families in groups? So we're constantly looking at new models of teaching others as well. But the question haunted us for the first 5 years as to how are we going to reach out to that second group of kids, the kids at risk. These are not the families who are going to find their way to a center in Parel. First of all, they don't even know that their child has developmental delays. Secondly, even if they do, they don't think anything can be done about it. And thirdly, even if they did know both those things, they lose a day's wages if they come to UMMEED. Right? So they're not going to come to UMMEED to get the services. So the answer seemed really, really intuitive to us, which was we need to get to them. Right? There are organizations out there that are already reaching out to children at risk, to children who are at risk because of poverty. And we felt that if we reached out to government organizations, NGOs, orphanages, if we reached out to them, then we would be able to build capacity in those organizations to work with these children at risk. In this came our Child Development Aid program. This is our flagship training program, and this was developed in 2008 with funding from USAID. It was a pilot at that time. We took a lot of effort to build a curriculum, and it was a four-point agenda. In 6 months, we wanted to teach one community health worker from each organization, build that person as a resource person who would A, promote child development in her community, B, identify young kids early when they had delays, C, teach their parents how to work with those kids, and 4, lastly, work specifically with children with disabilities. So we saw child development and children at risk and children with disabilities as a continuum. This program has just completed its 4th year of running. In the meantime, we also got it certified as a diploma course from Tata Institute of Social Sciences, so we have an academic affiliation for it. Parallelly, we have another program, which is a mental health training program, which is a specific part-time program focusing on mental health of families. Because interestingly, as high a risk as poverty is or being premature is, equally high is the risk of having a mother with depression. It affects your development. It's intuitive if you think about it. You can't expect a mother to play and sing to her child and talk to her child if she's depressed. These programs have in common that they're intensely hands-on. We're talking about community health workers who are 8th standard, 10th standard pass, Hindi speaking. They're very, very hands-on. It's not very theoretical. We have direct supervision for them, even when they go back to their own setting. And there is mentorship that continues for the life of the program. Over the years, we've realized that it's not easy for organizations to commit 6 months or even part-time, 9 months, as the second program is, to sending somebody to us for such a long time. So we've tried to tailor the programs to meet the needs of the organization. So for example, currently we have 2 pilots going on for a shorter version of the programs. One is with the Forbes Marshall Foundation, and one is, that's an urban slum in Pune, and the other one is Ambuja Cement Foundation, and we're doing rural poverty-stricken area in Maharashtra, in rural Maharashtra. And we're very happy with how things are going. I'd be happy to talk about it if anyone has questions. Here are some of our partners. Many of them are in the room. We have been really, really fortunate in having wonderful partners who have sought to send us people actually year after year. So what is the impact of what we do? And actually, before coming here, I talked to Jo Chopra from Latika Roy Foundation to ask her, well, what do you think it really happened? You know, she had 4 CDAs trained with us, child development aides trained with us. And what is remarkable to all of us, that it's a journey of personal transformation for all these women, mostly women and men. But the changes in the organization that she pointed out is, yes, they're reaching out to younger children now, especially in their inclusion programs. The other thing that's happened is that people are realizing the importance of being families, or being with families, teaching families and reaching out to them. And the third thing is suddenly now everybody is interested in getting trained. Who ever thought that somebody who's 8th grade pass in Hindi can get a diploma from Tata Institute of Social Sciences? So it's become aspirational for a lot of people in the organizations. And lastly, Jo was very kind, and she said that if she had the money and the time, she would send everybody for the training. So how many people has UMMEED reached out to date? We have reached out through direct services to 6,500 children, but what we're more interested in this presentation is actually the latter half, which is the fact that we've reached out to 22 NGOs, and we hope indirectly to about 25,000 children through them. How do I know that? Because of the funding we had from USAID, what was really neat is that we were able to go and look at the impact of what we do at another level. We went and did qualitative analysis. We had an external agency, actually, Barometer Research, do a qualitative analysis on what happened to the organizations where we did the training. And what we found was that there was indeed a cascade of learning. What happened was just not that the CDAs were transformed, but also their co-workers, the families they worked with, higher up. The changes actually rippled all the way through in different places. The other interesting thing that we found was not only about our success, but about our failures. Because where we did not succeed was when we invested in individuals. So unless we invested in organizations at various levels, not just training the CDA or the community health worker, but looking at the next level up and the next level below to make sure that we had investment at various levels in the organization, it wasn't as successful. So this is our team, and as you will see, it's a highly skilled team. We have pediatricians, psychologists, management professionals. John is here, who has a rich background in management. But what I think is unique about our team is that these are people with a great deal of skill, but can break it down to the simplest level for any parent or community health worker. I'm also really proud of the fact that we have spent the last 5 years intensely investing in organizational systems. So what do I know, right? I'm a doctor. I knew nothing about management. But I've been very fortunate to have a lot of support from people like John and people like Bob Sheelan, who has worked with us over years and helped to build systems in our organizations, such as supervision systems, mentoring systems, HR systems, communication. There are so many things that we have in place now. The other thing which I think is unique is our family-centered philosophy, which I've spoken about, and the fact that we see early childhood development and disability as a continuum. Lastly, in terms of credibility, we work closely with the Government of India. We are advisors to them on various bodies. We are also working with the WHO on 2 advisory panels related to early childhood development as well as disability. We're involved in a large research project which I would simply love to talk about, which involves 4 countries of low and middle income, and we are part of the Global Health Initiative at Children's Hospital, Boston. This is our board of directors, a wide range of people with varying backgrounds in disability, in the corporate world, as well as in the not-for-profit world. We meet regularly twice a year, but more than that, actually, we are intensely in contact with them. We reach out to them for hiring people, for fundraising, for advocacy, and a bunch of different things. This is our avenues of revenue. I won't dwell too much on this because it's a wide range of things. I want to point out, though, that we're still heavily dependent on individuals. It's something that reaches out to people personally, which can be a blessing and a problem, because at one level, it requires investment to sustain individual donations. So here are our numbers so far. Right on top, and this is through our training programs. Right on top, I want to point out to you the direct beneficiaries through our training program. So one trainee reaches out to so many children. And what you'll find is the numbers that we've increased over the last 3 years is pretty modest. What I want you to look at is under total budget, the second and the third slab says awareness creation, partner acquisition, and fundraising costs. And you'll see that they are really, really small. And I'm coming to why we are actually pitching for funding for that slab. And I'll, yeah, sure.
This program cost, I mean,
yeah.
what's the unit of it?
It's in lakhs, I'm sorry. All the numbers are in lakhs, yeah. So if you look at our challenge today, the challenge really is that reaching out to organizations is one thing who have access to young children. The problem is convincing them that they need to invest in early childhood development, right? It sounds like we have this great program, we are so credible, we've done this wonderful thing. We do not have people beating at our door saying, teach me this, right? And so in other words, in order to scale, we need to build the market. We just don't have the market ready yet. And to do that, we need to focus on that second slab under total budget, which is the awareness building costs. We need a team that builds awareness, and the fundraising costs actually to be self-sustaining as far as this is concerned. So this is what the projection looks like for us over the next 5 years. And I'm also including impact assessment costs because that is important too. We need to know, are we really reaching out to the number of kids that we're saying we are? What is the quality of our programs? I'm sorry. Want me to use my point? Okay. Yeah. So, so really, if you look at the beneficiaries, you'll see that it doesn't cost us so much more to increase our number of trainees. Per trainee, the cost is not so much. The training program costs tend to be solid. So what we have here is a total funding gap of 2.15 crores over 5 years. But most interestingly, in the next 5 years with that, what we could do is to reach out to 70,000 more children at half the cost. Because beneficiary costs go down as the number of people you train goes up. So here is Tanay, that little boy. He's now 6. He goes to a regular school. He's happy as a clam, as is his mother, who you can see at the back. But Tanay was lucky. He got to UMMEED, he got to a center that could give him care. There are many little kids like Prakash who don't have that chance. We could change that. Thank you.